on? Oh, you can. Okay. All right, that's good. I wasn't sure. But platelets really have, I don't even use this. You guys are okay, right? You can hear me. Okay. Platelets have a couple functions, right? They adhere, they activate, they degranulate. And they aggregate, okay? So the activation of platelets can be triggered by a lot of different things, right? There's ADP, there's oxidative stress, there's shear stress, right? There's exposure to the endothelium, exposure to different binding factors inside the vascularity, right? A lot of things can cause platelets to aggregate. The whole point, though, is that you have primary hemostasis, right? So you get a paper cut. You have to have the platelets they're extravasated through the blood vessels and go to that place. They're going to activate, they're going to form a primary platelet plug, and then they're going to degranulate and attract different cells to come, right? And they'll attract the mesenchymal stem cells out of the body. That's how you have that healing, okay? A lot of different things cause that to happen. Now, the thing is that you'll hear this talked about a lot, and people will say it's like yin and yang, right? Is platelets, is PRP, is it, what are we trying to do with regenerative medicine? And is it really regenerative, right? Is it an inflammatory process or is it an anti-inflammatory process? And I think it really depends on when you look at it in the healing cascade. I think that's one important thing about it. The other thing to think about is that when we use the word inflammation in medicine, we almost use it like it's an evil word, right? Because you understand what I'm saying? I don't know how you use it in Chinese, but like in English, when we talk about inflammation, we talk about it like something else on fire. So we always tell patients, oh, we're trying to reduce your inflammation. We're trying to reduce your inflammation. But the reality is that being on fire isn't really being on fire. It's really just part of the body's natural process at the beginning of trying to heal itself. So I'm kind of getting ahead of myself here, but it's important to understand though that like we talk about platelets like PRP, like that's the only thing that's going on. The reality is that there's not only that, but the second big thing inside that Buffy coat that we're really worried about is the leukocytes. And the leukocytes are actually a big part of that healing process as well. But one other thing that I won't even get into here is that what a lot of people end up throwing away, all this stuff up here inside the plasma, they found that there's a lot of things in there that are beneficial, right? They take away everything else, they plate that with, let's say, cartilage cells, chondrocytes, chondroblasts, and they show that they still can have antibiotic properties, right? They can show that then when they isolate the alpha-2 macroglobulin and they concentrate the proteins and they put that in with the chondroblasts or chondrocytes, you have downregulation of catabolic markers and upregulation of anabolic markers, right? You have TIMP, you have hyaluronidase, you have all these things that are going on. And the problem is that even when we study this, you think it's supposed to do this, like down fire, good, up with the good stuff, down with the bad stuff, right? But it doesn't always plan out like that in all the studies, and nobody really knows how to control for it. I hope this makes sense what I'm trying to say, but hopefully by the end of this talk it will be it. We won't go through this, but this is just that idea, right? So you get that initial paper cut, you have to have hemostasis, primary hemostasis, right? Then you have the platelets there, the neutrophils come, the lymphocytes come, macrophages come, and you have remodeling of the tissue at some point. I don't know if you guys know this, but they've done biopsy studies of lesions, right? You have a paper cut, maybe not a paper cut, but something a little bit deeper, like a wound, like a sacrodecubitus ulcer. Even though the skin is healed over, when they do a biopsy study, the integrity, the tensile integrity of that skin actually takes up to 12 months to be as good as some other part of the skin that didn't have it in the first place. So actually the remodeling takes a long period of time, and you have to give patients realistic expectations for our interventions. Okay? So, you see this, and they talk about 48 hours and 3 to 10 days and 21 days for remodeling, but the reality is that to have truly restoration of that tensile strength inside the tissue, integrity-wise, you can take months and months and months. Okay, so this is just that, right? You have stages healing, you have that initial inflammation period, and you take away the necrotic tissue, and the tissue remodels. Okay. There's going to be variability in your PRP efficacy, right? And then, so the real question is that how can we optimize these outcomes? Now, I think probably most of you are like do a ton of prolotherapy, and you guys are very, very experienced with exosomes and things like that. And I think these are the same principles, okay? I think it's important when specifically looking at PRP and bone marrow studies is that if you look at all the studies, there's various ways of obtaining the PRP. And it's not just obtaining PRP. You have to imagine that what really happens is that if I come and I take PK's blood in the morning, and then now after he's had a cup of coffee and a piece of sugar and a piece of cake, another cup of coffee, and then I take his blood again, do you think it's going to be different? Of course it's going to be different, right? And if he has lipids in it, is it going to change things? And if we process that, how is it going to change the growth factors that come out of platelets? And we'll talk a little bit about that. I don't want to get too deep into the basic science because that'll put you guys to sleep. It'll counteract all the coffee earlier. But this is one of the reasons why there's a lot of variability in the study outcomes, because our study protocols are very widely different. When I came to use what I use in my office, I probably went through about 15 different vendors, and I tried all the different companies that had PRP. And of course, we can use an expensive kit, we can use a really expensive kit, or we can use like 10-cent tubes, right? And a lot of people say, well, if at the end of the day, all we have to do is centrifuge the blood mechanically, right? It's really a mechanical process. Why should I spend so much money on a kit, right? I visited Morgan, who I admire. Morgan in his office, and he told me, actually, exosomes don't cost the same amount of money, or probably less than PRP kit. And you don't have to take blood from the patient, it saves time and the discomfort, there's all this pros, right? So why would you do it? This is a vendor that came, and this is one of the big companies in America. This is Orthobiologics, and they sell orthopedic spine hardware. And this is all digital. It's this big device, it's all digital, and he says, hey, I can digitally punch in what I want. And I said, okay, I want 0 red blood cells. He said, no problem, 0 red blood cells. And they punch it in digitally, and it comes out like this. What do you think? Right? 0 red blood cells, right? And it's funny, because I handed it to him. I said, what do you think? He said, perfect. I said, man. Right? So, same idea, you know? This is after a second spin. This is the guy who was one of the founders of this company. I won't use their name. We were at Yale and doing live cases, and same thing. Same exact thing that went in, came the same thing, same thing came out. So what's important to understand is that just because these products tell you that this is what they're giving you, doesn't mean that that's what you're getting, right? So you can understand why there's a lot of variability. Just in the device, right? This guy literally was the founder of this company. So you have to imagine, if anybody knows how to use the device, you should know how to use it, right? Okay. Mind you, I've been with this company for a long time. This isn't why I put this up here. We pull out 50 to 55 milliliters of blood, okay? You have to have a large enough dose of platelets, right? If you use a small tube, you only obtain a little bit. It doesn't matter how many times they concentrate. An old way of thinking about platelets is how many times it concentrates. But if I only pull 2 cc's of your blood, I don't care if I get every single last platelet in it, I'm only gonna get like a couple 100,000. Make sense? Actually, concentration is a foolish idea. If I pull off and I get rid of all of this plasma, it's gonna be an X amount of concentration. If I only pull up this very last bit, and it's only 1 cc, you can imagine it's a lot more concentrated, right? So then if I just double the volume, I just cut my concentration in half. You guys understand what I'm saying, right? Not? Okay. So, the question is more better? There's some studies that say that there's a possibility that you get to a point where it's too much, and it actually has a catabolic effect, or at least a ceiling effect. I don't really know, because, again, these studies are very difficult to reproduce and to have reproducible effects, okay? I will talk about what I think gives you a normal functioning platelet. And because these are some of the things that we can control. For most of you who are dealing with cash-based practice, right, you understand that your outcomes determine everything, right? Ray knows. You have to hit a home run. And I find it fascinating. When I'm here in Taiwan, the doctors always say, I have 1 chance. Daniel Su told me, well, right? I got 1 chance to make this work. And so the whole point of this, when you're dealing with cash, is that we have to put everything we can do to like push to make this successful for that patient to have a good outcome, and then they'll refer other people and they'll come back, right? So some simple things that you can do, right? What does the effect of exercise have on platelets? and platelet concentration in your blood. So I don't know if you know this, but about 30 to 50% of the platelets inside your whole body hang out in your spleen, okay? And they sit in your spleen, and all you have to do to liberate them is do like, I don't know, 5 minutes of exercise, rigorous exercise, semi-rigorous exercise. So I'll have my patients come in, not only, and we'll talk about what I tell them to eat and all that stuff beforehand. Before I draw their blood, I'll have them do like 5 minutes of either jogging in place or like, you know, some jumping jacks, whatever they can tolerate. Okay, ideally we do more than that. Get them so that they get a little glow, they get their heart rate going, but simple things. And they've shown that this is something that gets the platelets to come out of the bloodstream. They're not sure if it's just because you get the heart going or if it's because there's a release of epinephrine that causes it to come out. Because they've done studies where they put epinephrine directly into a mouse study, measure the platelets that are in the bloodstream, and just by administering epinephrine, it causes the platelet count to go up. But these are simple things that you can do. The thing that also happens, though, is that it changes the cytokine profile that comes out of the platelets. And that people aren't sure about, because when they measure these cytokines, there's like literally hundreds of them. Some of them go up in one study, some of them go down in another study. It's not, you're not 100% sure what is the actual outcome of what you're doing. At the very least, though, we're saying that if we want high platelet count, if we think that that's what we want, at the very least we know that, hey, you do like 20 minutes of brisk exercise right now, 10 minutes of exercise, at least I know that I'm going to get a higher yield. Okay, very simple, cost effective, right? And this talks about that. These are a couple of studies that talk about what you can do to help the platelet counts. So, the thing with chronic MSK disorders, right? People don't have, very few of us probably dealing with like super acute injuries. Because most people have acute injuries, they don't show up to your office the next day, right? They certainly wait and see if the body's gonna naturally heal itself, okay? But the thing is that that tissue is no longer, it changes, right? It's no longer as healthy as it was, right? You start to get, for instance, let's say you get a tendon tear, like a rotator cuff tear, right? Over time, if that tendon dies away, it tries to grow back, but the fibrils are not regular, right? You guys all do ultrasound, so you understand that. It's not, doesn't have that same pattern anymore, right? It's dysregular. Or you have atrophy around the muscle, and it's no longer muscle, it turns into fat, right? You cannot inject fat and expect it to turn back into muscle, right? Makes sense, right? So you have that idea, but either way, we have this chronic inflammation, you have tissue fibrosis, you have poor tissue vascularity, and this impedes angiogenesis. I'll tell you a secret, and this is really important. This is really bad for regen doctor. And this hasn't been shown in the studies. But it's good for all of you because you guys have incredible diagnostic skills, incredible ultrasound skills. And I know you all know this already, but putting the needle in the right place is 100 times more important than whatever you put in the, right? Right? You guys know that, right? Putting the needle in the right place. And I know you know, that's why we keep talking about root cause, right? Right? Makes sense, right? Put the needle in the right place. So, I think that's the big part of it. So, we talk about leukocyte rich and leukocyte poor. And here's the reality. Here's another part of the reality. Wait, actually, let me backtrack before I get into this. So, putting the needle in the right place, here's where it comes down to it, though. There's been studies that have compared dry needling, finding the right place, needle it, versus finding the right place and needle it and add PRP. And the reality is that both arms do better than conventional care, like physical therapy. The reality is that the PRP arm might do a little bit better, but I don't know if it always justifies the cost, right? So some of the studies out of the University of Michigan, oh God, what's the radiologist out of the University of Michigan? You guys invite him to Taiwan probably all the time. Oh, come on. What's his name?
John Jacobson.
Jacobson, thank you, right? So Jacobson did a study looking at glute greater stroke under pain, right? Glute med tendinopathy at the insertion, right? And they, I think it's 40 in one arm, 40 on another arm. They've just, you know, they see it, they needle it, and then the other arm they needle and they add PRP. And maybe the arm that got PRP, I think they got better like 1 or 2 weeks faster, okay? Which, you know, I don't know. But again, if you put it in the right place, remember, what are we doing? We're really just trying to stimulate trauma. We're just trying to jumpstart the healing process again, right? Okay, so here's another thing that people talk about that I don't know if is 100% possible. They like to talk about leukocyte rich and leukocyte poor. And if you look at the studies that have at least say that, even though you can't tell how they determine if it's leukocyte rich or poor, Most of the studies show that if you put leukocyte-rich PRP into a tendon, it does better than if you put leukocyte-poor into a tendon. And if you put leukocyte-rich into a joint, strictly into a joint, versus leukocyte-poor, probably cause a little bit more pain, and it may or may not be as good. The reality is that if you've ever processed PRP, you realize that when you get that buffy coat, it's the leukocytes and the platelets. It's very hard for you to say, well, I'm going to spin it at less time or less G-forces and try to have less of the leukocytes. You understand what I'm saying, right? Because they're right there. They're right next to each other. The other thing that you have to really recognize that in all of these studies, especially the ones that come from the West, is that they talk about the knee joint like it's like just one cave, right? When you guys are treating a knee, you have a different diagnosis for the front of the knee, the side of the knee, the lateral recess, the corner, all that stuff, right? And you're trying to target each one of the things as a specific pathology. You don't just say, knee pain, or PRP, right? Because it's all intra-articular in these studies. It's a very, I hate to say it, but it's a very crude way of thinking about it, right? It's like a caudal epidural for anything. Anybody who has back pain gets a caudal epidural, right? It doesn't matter if it's L3, L2, L1. It doesn't matter if it's facet pain, right? And so you have to think, these studies have a problem, there's problems with that, okay? Anyways, I think what we really do need is to actually end up just giving everybody leukocyte-rich stuff, but hitting all the soft tissue structures around. I will save the plasma. I used to throw it away. And I save the plasma, I stick it in the joint. What's the worst that it can do, right? I do think that it's a chance, if you do enough of this, you see that, probably 40–50% of patients will have post-injection pain flare. I think the white blood cells cause an immediate cytokine storm inside that area, right? You think about it, concentrate it down to like 1–2 milliliters, and I stick it into your tendon. And I take every white blood cell and 50 milliliters of blood, right? And I stick it into this one little spot. And they degranulate. And they create this, huge storm. It's gonna hurt, okay? All right, let's go on. So we're gonna talk about that. But I think the reality though is that, remember, the body already knows what it's trying to do, right? Doesn't matter if I take bone marrow, if you take adipose, or if I do PRP and I go leukocyte-rich or leukocyte-poor and all this stuff. Remember, because those studies say if we needle the right place, the body's gonna know what to do. It knows what's gonna happen next, right? I just create a new injury. So, we try all these things and we put it there, and we're hoping that in our minds we think, this is day one. I don't know if you get what I'm saying, but it's not day one. The body already knew what to do even before you did anything, right? So, no matter what, if we put bone marrow there that has stem cells in it, even if we put platelets there and there, the platelets, when they degranulate, will recruit stem cells from the body, right? You see what I'm saying? They're already there. We just have to figure out how to get this healing process to move forward, okay? So clinically, right, I think it's important to pick the right patients, right? Again, we have to set right expectations for our patients, right? I'm not gonna make you 17. I'm not gonna make you taller. I'm not gonna make you stronger, right? What can I realistically do for you? And then you also have to realize that not all people are gonna be responders for these therapies, right? This is probably not gonna be a PRP patient. Okay? I'm gonna finish, I'm gonna keep going. Some of these though, a lot of these are gonna be PRP patients, right? You guys see these, it's plantar fasciitis, it's tendinopathy, this stuff, right? Okay? What about the patient factors, right? You have people who are professional athletes. I used to see them professional athletes. They are on top of it. You tell them don't do this for 10 days, they will count, right? 240 hours, okay? You have other people, right? You have other people like this guy and other people, everybody's different, okay? You recognize that there's gonna be individual patient factors that are going to affect the success of your outcomes. Doesn't matter if it's PRP, doesn't matter, or is it epidural, or it's a total hip replacement, right? These are things that I think are gonna affect them. Hyperbaric oxygen. So some of my friends who are really into this and they have really wealthy clients, right? You line them up for a whole package. You get this, you get this, you get vitamins, you get this, you get this. We send you to hyperbaric oxygen therapy, right? 4 times a week. It's like $200 a session, right? Everything. It's just how much money you have, right? And how invested you are in getting better. Hyperbaric oxygen therapy, right? Look at this. They do this for skin healing. It's been shown to improve healing outcomes, right? The question is that what's available to you and what are your resources, okay? what I like to focus on are things that are easier to control. I tell them, okay, listen, we're gonna do this in a month, right? This is what I want you to do. These things I want you to eat beforehand, right? I want you to cut all the caffeine and alcohol, or I want you to do this, I want you to do this. I want you to try to live healthy. I want you to try to live the way you're supposed to live anyway, okay? And I'm not gonna go through this because it's weird, because you'll see these things and they'll say, oh, well, garlic affects your plates. Obviously we know it affects bleeding, right? Keep in mind, by the way, when I talk about what's normal function, think of your heart rate. Normal heart rate's supposed to be like X amount, right? If you see a heart rate of 300, you know there's something wrong there. You see a heart rate of 30, it's probably something not so good there either, right? So we're just trying to maintain normal physiological function, because you'll see this slide, you say, well, George said this makes the platelets do this, and this makes the platelets do that. And you say, what am I supposed to tell my patients to do? We say, well, really, we're just trying to get back to normal homeostasis. Try to avoid these things, right? Stop smoking. Don't drink alcohol. Don't do this. Don't do that. Okay? And there's a lot of medications. A lot of these they certainly cannot stop taking, right? But a lot of the medications we prescribe for patients who are in chronic pain or depression affect serotonin. And most of the serotonin is actually sequestered inside your platelets and all of your body. All serotonin is mostly there. We prescribe them these meds, right? NSAIDs and anticoagulants, TCAs, etc. Okay? And this has been shown. People looked at this, and I don't have time to go through this because I don't know how much time I have left, but they've looked at not just how the platelets function, but they've also looked at the platelet-derived growth factors and things like that, and IL-1, IL-6, IL-1 beta, all this stuff. Just naproxen, simple NSAID, can affect all of these things. This is not just how the platelet acts. It affects the growth factors that come out of that. So if you're only taking naproxen, like if you're taking aspirin because you have stenosis in the brain, sure, maybe we don't stop that. But if you're taking it just because you're taking it for pain, okay, let's stop that. Okay? I'm going to keep going. Yeah. Okay. Platelets contain 99% of all the whole blood serotonin in your body. So just imagine that every medication you give people that affects the serotonin, right? When we give people an SSRI, like Broxetine was studied, serotonin decreases by more than 80%. It's going to affect how your platelets act. They did a huge Annals of Internal Medicine review. They looked at over 500,000 cases, and they showed that purely being on SSRI increased your risk for bleeding post-surgery by about 1%. Is it a huge increase? I'm not sure, but it definitely has an effect on people, okay? All right, let me get this done. I think it's important to look at the science and the literature and to look at what's been studied and what actually works well. For the people who do this, it's not so much the indications, it's more like we look at the tissue types that respond to it, right? Like we treat a lot of tendons and we treat ligaments because we think those will respond well, right? Injecting directly into the joint and trying to affect the cartilage probably is not really going to do a whole lot, okay? And I think that's the problem with a lot of the studies because they just directly into that. This is tennis level, right? There's like 25 studies looking at this. Level 1 randomized controlled trials across the globe. I'm out of time. Okay. I think it's important you guys all know to use image guidance. Am I out of time? Out of time? All right. Give me 2 seconds. This is a patient of mine. He was already scheduled for a surgery. Obviously, this is it's almost looks like a full thickness tear. And if you know, the supraspinatus has multiple layers, and it goes from the articular surface up. He didn't believe me. He was already scheduled 3 weeks from having surgery to pure lupus average PRP directly into his tear and around it. And I just saw him, like, this is like 6-7 years ago. I just saw him at a meeting. He's a pain doctor. 2 months ago, and he's doing phenomenally. He thanks me every time. He says, you saved me from having surgery. Let me just move this along. I want to finish because these are important. Local aesthetics decrease platelet function. If you can avoid polluting your PRP or your bone marrow, whatever you're doing, your exosomes, polluting with local anesthetics, avoid that. Avoid polluting with contrast. People are going to talk about discography, right? People who do discograms and then want to try to revive disc with bone marrow, whatever. I don't really do that. I don't really believe in it, to be honest with you. I don't think the efficacy is that good. But adding a contrast directly impairs mesenchymal stem cells, okay? If you see on fluoroscopy on AP and lateral, you're in the middle of the disc, you're in the middle of the disc. You don't need contrast to determine that, okay? And then this is a peer group study. This is looking at dashboards. This is really on shoulder hand. The whole point is just to say that it takes a long time to rebuild a house, right? It takes a long time for tissue re-engineering. So you have to give them realistic expectations. You guys can have these studies, obviously. I don't have time to go through this. We already talked about all this though. Brisk exercise, relative immobilization afterwards, we didn't talk about that. You have to send the high quality physical therapy. If you're gonna take a picture of any slide, this is probably the one. Okay? I'll give you a second. Just kidding. So, manage the expectations, avoid polluting your injectate with lidocaine and all this other stuff. And that's it. Thank you. Sorry for
Good morning, I'm Zach McCormick.